Good afternoon, everyone. Thank you for joining me today. My name is Dr. Said, and I am pleased to present our study titled Correlation of the Endoscopic Esophagogastric Junction Integrity with Symptomatic GERD in Patients Undergoing Workup for Bariatric Surgery. Today, I will walk you through the key findings of our study and discuss the implications of these results for clinical practice. Bariatric surgery remains the most effective treatment for obesity and its related comorbidities. However, GERD is a common adverse effect following bariatric procedures, particularly after laparoscopic sleeve gastrectomy. The mechanisms of reflux and potential solutions are subjects of ongoing discussion and research. It's important to have a mechanism to determine preoperatively which patients have pre-existing GERD for appropriate counseling and procedural selection. While pH monitoring provides objective results, it's not practical to perform this test on every patient. The Hill classification has been criticized for its subjective parameters and vague criteria, which contribute to inter-observer variability. Considering these critical limitations, the new American Foregut Society classification has been proposed as a more comprehensive and reliable method for evaluating the anatomical components of the anti-reflux barrier. The aim of the study was to evaluate the utility of this classification in analyzing EGJ integrity in patients with obesity. We conducted a prospective observational study at a single high-volume center, focusing on severely obese patients who underwent upper endoscopy as a part of the preoperative evaluation for primary bariatric surgery. We recorded age, gender, BMI, and the use of proton pump inhibitors and antacid medications. Patients currently using antacid medications were excluded due to the potential symptom-suppressing effects of these drugs. All patients also participated in face-to-face interviews preoperatively, during which they completed the GERD HRQL, the GERD-Q, and the RSI surveys. All patients were also evaluated by endoscopy, identifying the presence of esophagitis based on Los Angeles classification and EGJ integrity using the AFS hiatus grading system. The Hill grade is based only on the appearance of the flap valve, but the new AFS classification differs by not only focusing on the flap valve but also on the anatomical disruption of the hiatus. This includes assessing the diameter of the hiatal orifice and the axial extent of hiatal herniation, measured by the distance between the Z-line and the diaphragmatic indentation. Importantly, it uses a standard endoscopic method, insufflating the stomach for 30 to 45 seconds or until the gastric fundus rugul falls flattened, followed by rotational maneuvers in the retroflex position to induce the potential sliding hiatal herniation. The worst finding determines the final grade. You can see a grade 2 patient on the left side and a grade 4 patient on the right side as an example. As a primary outcome, we analyzed the correlation between AFS grades and the scores. For the secondary outcome, we examined the distribution of patients diagnosed with esophagitis across the AFS grades. After excluding 63 patients due to revision surgeries or antacid usage, 393 patients remained in the study. Of these, 81% were female with a mean age of 36 and a mean BMI of 41. As shown in the table, the majority of patients fell into grade 2 and grade 3. This bar chart shows the mean GERD HRQL scores across AFS grades. There is a clear upward trend from 0.36 in grade 1 to 9.41 in grade 4, indicating that more severe anatomical disruptions are linked to greater impairment in health-related quality of life due to reflux symptoms. Similarly, we observed the same trend in the mean scores for heartburn and regurgitation, which are the components of the GERD HRQL. The GERD-Q and RSI results also demonstrate an upward trend in mean scores. And this box plot shows the distribution of GERD HRQL scores across grades, highlighting the median scores rise with higher grades, the presence of outliers and the broader interquartile ranges at higher grades indicate greater variability in symptom severity. And we performed a Spearman correlation test as the data has an abnormal distribution. As we can see, the correlation coefficients are all positive but fall within the range of 0.2 to 0.4, indicating a weak correlation. It's a positive but a weak correlation. When we come to the esophagitis rates across the groups, as AFS grades increase, the percentage of patients with esophagitis also increases. Each AFS grade group differs significantly from each other based on the Pearson chi-square test. This study is the first to validate the AFS classification in patients with obesity with a large patient population. Although we used validated questionnaires, incorporating pH monitoring would be more objective. In conclusion, the AFS classification shows a weak correlation with reflux scores. However, esophagitis rates as an objective measure increase stepwise with AFS grades with significant differences between each grade. Validation should be based on objective rather than subjective parameters. This study supports the practical utility of this AFS classification in clinical settings. Future directions include validation studies with objective testing. And I want to express my deepest gratitude to Dr. Nguyen for his exceptional support and invaluable contribution to this work. Thank you all for your attention and engagement today.